Dr. Anna Choy joined our AIMS group this year because her PhD student, Jeffrey Wang, who has now achieved his PhD successfully, had found that a substance called desmosine, if measured in the samples from our AIMS trial, first of all reflected the breakdown in the aortic wall. And then when we gave them irbesartan, which was our trial, this situation seemed to improve. And this we found absolutely fascinating. So we've continued to collaborate. Now, Anna Maria is unavailable today, but she's recorded her talk, and Jeffrey is with us to answer questions afterward. So perhaps we could now go on to the role of desmosine in aortic aneurysm. And desmosine is another component of the elastic tissue in the body.
Good afternoon. My name is Anna Maria Choy. I'm a cardiologist at the University of Dundee, based in Ninewells Hospital Medical School in Scotland, and it gives me great pleasure to be here today to share our exciting research looking at desmosine, a new biomarker in inherited and acquired aortopathies. I'd like to talk about some of the work we've been doing in Marfan syndrome using desmosine, and it gives me great pleasure to thank the organizers of this meeting, particularly Dr. N. Charles, for giving us this opportunity. The focus of my talk today are aortic aneurysms. Aneurysms are swellings in an artery that can occur anywhere in the arterial system, but it most commonly occurs in the aorta. The aorta is the largest blood vessel in the body. It extends from the heart all the way to the abdomen. There are two areas in the aorta that commonly develop aneurysms. This is the thoracic aorta and the abdominal aorta. Both these types of aneurysms have a risk of serious life-threatening complications from progressive aortic dilatation, leading ultimately to rupture. Thoracic aortic aneurysms affect 10 in 100,000 adults above the age of 55 and are commonly asymptomatic. Abdominal aortic aneurysms affect 9% of adults above the age of 65 and account for 15,000 deaths each year in the United States. And as a result, in many Western countries, there have been national screening programs for men above the age of 65 to diagnose silent aortic aneurysms, and if they are found to have an aneurysm, they are invited for follow-up by annual imaging testing. Now, imaging surveillance is the current mainstay of managing aortic aneurysms. We invite patients to have their aorta scanned each year, and we monitor for growth. If the growth of the aorta exceeds a certain size where it's deemed to be at risk of rupturing, then elective surgery is arranged before the rupture can occur. There are many ways we can screen and monitor for aortic growth using ultrasound for the abdominal aortic aneurysms, but for many of the genetic aortic aneurysms, which are thoracic, we use echocardiography and occasionally CT and MRI scanning. The national screening program has been very successful for abdominal aortic aneurysms. In fact, the incidence of rupture has been reduced significantly by 55% through these screening programs. Unfortunately, we don't have the same system in place for the thoracic aortic aneurysms, and therefore patients often present with a life-threatening event, and it's not surprised that these conditions are sometimes called silent killers. Although surveillance by imaging in these national programs has been successful, there are still instances where we find it has its limitations. This is for a number of reasons. We now recognize that the way the aneurysm grows, it is not in a predictable manner. It often expands and grows in a stepwise fashion. We've seen aneurysms that stay the same size for many years but suddenly expand and go into rupture quite abruptly. We also know that aneurysms can even rupture when they are not considered large and at a stage where they require surgery. Screening by imaging requires patients to attend a hospital department, and this has clear impact on resources, particularly at a time such as the pandemic, where access to hospitals has been very limited and restricted, meaning that surveillance programs may have not been carried out. And lastly, quality of images. Sometimes with these imaging procedures, it's not of a quality that allows us to make confident clinical decisions, particularly when it's to operate or not to operate. So for all these reasons, we sometimes wish for a better way of assessing patients' risk and how an aneurysm is going to behave in future. And ideally, if there's a chemical that is found in blood or urine that can provide useful clinical information on the aneurysm and its prognosis, this would represent an ideal biomarker and test that we could use in addition to the imaging information. Now, when we try and think of a test that would be ideal, it's a test that would have to involve the disease process and be directly related to the disease process. And I'd like to perhaps talk about the structure of the aorta, because this is important when we try to develop a biomarker or a test. This is a diagram of the aorta in cross-section. You can see that it's made up of different types of tissue, muscle cells, but importantly for us, it's made up of sheets of elastin fibers. Elastin is a very strong and stable protein that gives the aorta its elasticity, enabling it to stretch and recoil with each heartbeat and wave of blood flow. In aortic diseases, there's degeneration of this aortic wall, including the elastin tissue, and this causes the aorta to become weakened and to expand over time, resulting in the aneurysm. And we now know that elastin tissue is a key, elastin breakdown is a key process in the development of an aneurysm. Elastin breaks down and it releases elastin breakdown products. These chemicals or molecules are released into the bloodstream and eventually in the urine. And they, if we can measure them, can be a useful indicator or biomarker of the disease process. We would be able to measure these biomarkers, and if it is elevated, we can assume that there's ongoing or active disease. Now, desmosine is such a molecule that is released from the breakdown of elastin. This diagram shows elastin fibers depicted in green here. Elastic fibers are joined together to form sheets of elastin material, and these connections that hold elastin fibers together is this molecule called desmosine, seen in red here. Now, when elastin fibers are broken down for whatever reason, these desmosine fragments are released into the bloodstream where they can be measured. Measuring desmosine has been a challenge, and for many years there has not been a reliable assay to do this. My colleague in the University of Dundee in the medical school, Dr. Jeffrey Huang, however, has been able to develop a unique technique to do this. It's a technique that's very reliable and has allowed us to embark on a research program looking at desmosine in a variety of disease conditions. Dr. Huang's laboratory is currently the only laboratory in the world that is able to measure desmosine reliably in this manner, so we are very fortunate to have him and his expertise as part of this program and in research. Using the assay done in Dr. Huang's lab, we've been able to embark on a number of research studies looking at desmosine in different types of aortopathies, the genetic aortopathies as well as the acquired aortopathies. And we were interested to ask the research question, is desmosine increased in these aortopathies? Is there a difference according to the type of aortopathy? Does desmosine relate to aortic size and growth? And does it predict future complications? We've looked at a number of disease conditions, but what I'd like to next share with you is our research into patients with Marfan syndrome as part of the AIM study. The AIM study was one of the largest studies in Marfan syndrome. It was a UK study. Some of you may have participated in the study or have heard of it. It was a large study enrolling nearly 200 patients, and it was done over a 5-year period. The objective of the AIM study was to look at the effect of irbesartan, a medication usually used in blood pressure, but to look at its role in reducing aortic size in patients with Marfan syndrome compared to placebo. And what the AIM study found was that irbesartan was much better than placebo at slowing down aortic expansion in patients with Marfan syndrome. Now, the AIM study was positive, but previous studies looking at other angiotensin blockers, particularly losartan, have not seemed to show the same benefit that was seen in the AIM study. And there may be a number of reasons for this. It could be that these trials included people of all ages. They were quite a mixed group. Some of the participants were children, and the ages ranged right up to beyond middle age. So there could be a different effect of these drugs according to the age of the patient with Marfan syndrome. What we do see from these previous trials is that it seems that in younger people there seems to be more benefit to these medications, and in fact the younger the age when the treatment is started, the greater the benefit. And in fact, when we go back to the AIMS trial, when we looked at the younger patients compared to the older patients, we saw the same trend, that there was slower aortic growth with irbesartan in younger people compared to the older group. So this led us to our research question, which was, is there a difference in elastin activity in younger Marfan's people compared to the older people? And in particular, how does this compare to people without Marfan syndrome? So using plasma samples that were obtained as part of the study in the AIMS trial, we were able to measure desmosine in the same subjects that were enrolled into AIMS. We used desmosine to ask the question, what happens to elastin in the aorta during aortic growth in childhood compared to adulthood in Marfan syndrome and in non-Marfan syndrome? And is there more elastin breakdown compared to people without Marfan syndrome? These are the results. Now, AIMS was quite a unique study because a third of the subjects that were enrolled were very young. They were below the age of 20. And this allowed us to look at the pattern of elastin activity and elastin breakdown over the ages, particularly during childhood into adolescence, just before puberty. And what we can see here is the pattern of elastin release, both in Marfan subjects and in people without Marfan syndrome, in our controls. In red are the Marfan syndrome, and in blue are the controls. Now I can draw your attention to the group below the age of 20. We can see that plasma desmosine gradually increases in controls to its puberty, and then it falls and starts to level off in adulthood. In patients with Marfan syndrome, we see a similar phenomena. There is an increase in desmosine being released, suggesting increased elastin breakdown, and then towards puberty, and then it starts to peter off and reaches the same levels as controls in adulthood. So clearly, there's increased elastin breakdown according to age in both controls and in Marfan syndrome subjects. But when we looked at plasma desmosine according to age group, as seen in this slide here, we saw that in the age groups less than 15 and 15 to 25, for both the controls and the Marfan syndrome subjects, these groups had the highest desmosine levels, implying this was where this was a time when there was greatest elastin breakdown. In adulthood, adulthood had the lowest values of desmosine, and there was not significant difference between the controls and the Marfan syndrome subjects, suggesting that elastin breakdown is not is not so high in adulthood in Marfan syndrome. But clearly, all the action seems to be happening in the younger age groups. So we were able to conclude from this sub-study of the AIMS trial is that childhood appears to be associated with increased elastin turnover during growth, and in Marfan syndrome this is exaggerated from an early age, suggesting an early onset of aortopathy. In contrast, in adulthood, desmosine levels were not significantly elevated, indicating that the aortic root growth in adulthood is not necessarily associated with increased elastin breakdown, but actually may be caused by other factors such as blood pressure. Our most important finding, however, seems to suggest that early childhood is a vulnerable period in the development of aortopathy and presents an important opportunity for disease-modifying intervention with using drugs like irbesartan. But clearly, this is something that needs to be tested. I'd like to talk about another part of our research, and this was looking at desmosine as a biomarker for aortic rupture. For Marfan patients, aortic rupture is one of the most feared complications. But for many people with aortic aneurysms, it's usually a silent condition, and therefore it's never diagnosed. And this means that treatment opportunities are often missed. Tearing and rupture of an aortic aneurysm therefore often happens in an undiagnosed patient, and this often leads to fatal consequences. Once the aorta starts to tear, it's very important that a diagnosis is made quickly, because early surgical repair can be life-saving. Unfortunately, when an aorta tears, there's often a delay in diagnosis, and this is an important factor in the high fertility rate associated with aortic tears. So therefore, to have a blood test for such catastrophic events would really speed up the diagnosis and help us improve survival. So our research question was whether we could use desmosine as a biomarker in acute aortic tears. And we asked the question, do aortic tears result in release of desmosine? And if so, how much was released? And was it released to a level where it could be useful to diagnose aortic tears? We undertook a study with colleagues from Edinburgh and Singapore. And these are the results here. We were able to show that in patients who had acute thoracic aneurysm tears, that their levels of desmosine were significantly higher compared to normal healthy controls, shown in pink here. The highest levels were found in patients who presented at the very early stages of their aortic tear, seen in light green here. And even as the aortic tear was healing, the levels of desmosine were still elevated. Now, these levels of desmosine were clearly very high compared to the normal controls, high enough to a level that would suggest we could use this as a blood test to diagnose aortic tears. We were very pleased to be able to present these results at the recent European Society of Cardiology conference and the British Cardiovascular Society this year. Our presentation showed that desmosine was a promising biomarker for early identification and risk assessment in patients with aneurysm tears, and it was a story that was picked up by the British Heart Foundation. In addition to Marfan syndrome, we've looked at other genetic conditions associated with aortopathy. Bicuspid aortic valve is one of them. It's a very common congenital cardiac abnormality, and it's associated with aortopathies that have a 5-fold risk of aortic dissection. So we were interested to see if desmosine is also associated with aortopathy in these patients. This is a study we did looking at patients with bicuspid aortic valve and aortopathy, and we looked at urine desmosine in these patients compared to controls. And you can see here on the left that urinary desmosine was significantly increased compared to healthy controls, and it seemed to correlate quite directly with aortic size. We are still investigating why urine appears to be a better marker in these patients, but is clearly telling us a story that needs further investigation. The abdominal aortic aneurysms are another area of our research. We were fortunate to be able to collaborate with colleagues from Professor Matt Bowen in Leicester, as well as in Edinburgh, and we were able to show that in patients with abdominal aortic aneurysms that plasma desmosine was again elevated compared to controls. The more severe the dilatation seen here in blue, the higher the desmosine levels. In this study, we were able to show that not only does desmosine appear to be associated with the size of the aneurysm, but it also seemed to be associated with outcomes and complications related to the abdominal aneurysm. In blue, this slide shows the survival in patients according to their desmosine level, and in blue are patients with high desmosine levels, and in red those with low desmosine levels. And what this slide shows that your survival is reduced in terms of having these complications if you had a high desmosine level. So we were able to conclude from the study that plasma desmosine is increased in patients with abdominal aortic aneurysms, and it was significantly associated with the diameter. It was associated with aneurysm complications, and compared to other biomarkers, it was the best performing one. But this is not enough, and we clearly need to do another trial to confirm these findings. I hope I've been able to share with you some of our findings in this short period of time. From all our work, we've been able to conclude that elastin breakdown is part of normal aortic development in childhood and growth, but in Marfan syndrome, this is exaggerated and perhaps reflects the early onset of aortopathy. We've shown that desmosine is a potential tool to diagnose aortic tears by a simple blood test, and we hope that one day this may translate into lives being saved because of faster diagnosis. We've shown that desmosine can help understand the disease process in other inherited aortopathies such as bicuspid valve. We've shown that desmosine can help identify patients with abdominal aortic aneurysms who are at increased cardiovascular complications, and this may allow doctors to target these higher risk patients to start more intensive preventive therapies. Clearly, this is just a start of an exciting research program, and we have hopes to do further research, particularly looking at desmosine as a marker in aortic tears. One area that I'm particularly passionate about is the finding that young children are at particular risk of developing aortopathy, and that the opportunity to intervene in Marfan syndrome is at a younger age than what we are currently doing. And it is my aspiration that we maybe one day be able to do a clinical trial to show this, to show that early treatment is far better than what we currently do now in terms of preventing aortopathy developing in adulthood. I'd like to thank you so much for your attention and your interest in my talk and in our research. My colleague, Dr. Jeffrey Hong, will be happy to take questions. And in fact, if you have any questions that you'd like to email me, I'm happy to share my email if you would like to send me your comments or queries. Thank you very much. And lastly, I'd like to thank all the patients and the healthy volunteers who've made these studies possible, and my colleagues, Dr. Jeffrey Huang, my research fellow, Dr. Zaida Iskander, and all our support and collaborators. Thank you.
This is so exciting. We wanted everyone to hear the very cutting edge research that's going on at the University of Dundee. Jeffrey, you're with us. Do you think that this test of plasma desmosine will be put into practice in the same way that when a man comes in with chest pain and suspected heart attack, a troponin level is taken? Do you think that desmosine is going to prove to be a practical screening test in the accident and emergency department?
Yes, I certainly hope so. I think that's the direction we are taking. I think all the data we have is showing very, very encouraging results. So I think the key here is trying to see if we can use this test to pick up those high risk patients for the preventative surgery or the medication. I think this is the direction we are taking. I think this is very, very important.
And we are together planning further work for children under the age of 6, where irbesartan isn't yet approved for use. And yet the children tolerate it very well from age 6 upward. Because we're a bit concerned as a group that although we've shown that irbesartan is effective in delaying aortic root widening, it's not being given to the small children 0 to 6, where the aorta is growing maximally. Do you think we should be pushing for this?
I think so. So the data, I think the whole data suggests that a lot of elastin turnover happening in the young children, and I think that's a lot of pathological changes happening there. So early intervention does make sense, but certainly this require further research. We need to know for example, does the irbesartan reduce the desmosine level? Can we see a decrease there as a sign of the reduction of the disease activity? And that would tell us whether the drug is working or not. And I think that would be providing a good indication there.
Thank you very much. And Anna's looking for funding for that study from Scotland to give British Heart Foundation a breather, because they funded to the tune of about 5 million our first trial of irbesartan that many of our patients took part in. So the work continues, and it's all very positive. Thank you for joining us.